Good afternoon, everybody. It's 1:01. Welcome to the community of interest in breast pathology. We're really happy to see so many participants today. It will be a little bit unusual meeting. We'll have a very interesting presentation followed by a case presentation from our audience. As usual, please remember to put your questions in the chat and consider filling out evaluation. It's really important for us because we always review and we try to follow your recommendations. It is my pleasure to introduce Dr. Rachel Han from Sunnybrook, who is joining as a co-organizer of those breast communities of interest, to Dr. Jessie Wu, whom you see on the screen, and our usual experts, Dr. Sharon Nofech-Mozes from Sunnybrook and Dr. Anna-Marie Mulligan from University Health Network. Jessie, the floor is yours, and have a great session, everybody.
All right. Thank you, Anna. So good afternoon, everyone. Welcome to the Winter 2024 Breast Community of Interest meeting. Thank you so much for joining us today. My name is Jessie Wu. I'm a breast pathologist based at St. Michael's Hospital here in Toronto, and I'm also the host for this meeting. We've got a fantastic program for you today. We are going to start the meeting with a lecture from Dr. David Cescon from Princess Margaret Cancer Center on PD-L1 testing in triple-negative breast cancer, who, how, when, and why. I mean, from my own practice, I've started sending out PD-L1 results at the beginning of this year. And in all honesty, it has been challenging. I'm sure many of you feel the same way as well. So today we'll get an opportunity to actually learn more about PD-L1 testing from the clinical perspective. And this lecture is going to be followed by a Q&A session. And then we'll have our kind of usual presentations of interesting cases afterwards. So it's a real pleasure introducing Dr. David Cescon today. He's a medical oncologist and a clinician scientist at the Princess Margaret Center here in Toronto. Dave is a clinician scientist in the truest sense of the word. His clinical practice is devoted to the care of patients with breast cancer, and in particular, the triple-negative breast cancer and early phase trials. His research integrates laboratory and clinical studies, focusing on the delivery of precision therapy to improve breast cancer outcomes, specifically kind of identification of breast cancer therapeutic vulnerabilities and determinants of drug response and resistance. He's also one of the
Jessie, I have to stop you, or we'll never get through. I prefer a short introduction, so thanks for having me.
All right, I'll let you go ahead.
Everyone this afternoon, maybe we'll just jump into it. Are you seeing the full screen, or are you seeing the presenter view?
Presenter view.
Okay, let me swap to displays. Okay, so again, thanks for that gracious introduction, but I don't know who provided it to you. It's too long. As you heard, I'm a breast medical oncologist, and what I was asked to present a bit on why we're doing PD-L1 testing, what the role for this is. And what I thought might be useful is to sort of, go through some of how immunotherapy was developed for triple-negative breast cancer, which I think illuminates why we're doing it and where we're doing it. And then, of course, we can zero in on those key questions from a pathology standpoint. But I thought sort of telling the story of how immunotherapy became ingrained in both advanced breast cancer and now early breast cancer will be helpful as we contextualize this and think about how its role has evolved as we sort of redefine triple-negative breast cancer as well. So please feel free to interrupt me. I was told I have about half an hour. I'm happy to be shorter, happy to talk longer, but I can see some people on the side of my screen here, so feel free to interrupt. I think the more interactive this is, the more valuable will be for all of us. Okay, so without further ado, find the right buttons here. Whoops. I gotta go full screen, full screen. There we go. So here's my disclosures. So here's the objectives for the next 25 minutes or so: to review the current status of immunotherapy for metastatic breast cancer, address how the integration of immunotherapy has now become standard in the management of early breast cancer, and to highlight some of the ongoing clinical development and where these biomarkers really play a key role, both in our clinical practice and in the conduct of ongoing clinical trials, which are seeking to further inform the standard of care that we use today. So, breast cancer was certainly not the first disease where solid tumor or immunotherapy became standard. This is a calendar you can see on the left starting around 2014, where we saw the first approvals for CTLA-4, PD-L1 inhibitors in melanoma, and then advancing down into 2019 when we saw the first approval in breast cancer. I don't know why the arrow's pointing to the endometrial cancer column. It got out of line a bit. But first approval for immunotherapy in 2019. And in fact, this was not the immunotherapy that we're currently using. And I'll tell that story a little bit. But despite being one of the later cancers where immunotherapy was approved for metastatic disease, breast cancer is actually one of the earliest cancers where immunotherapy has really been ingrained into the management of early stage disease as neoadjuvant and adjuvant treatment for triple-negative breast cancer. Again, most of the discussion will focus on TNBC today, but I think we'll need to think carefully about, what is TNBC, and also it anticipates a little bit where the role of immunotherapy is coming in hormone receptor positive disease. Okay, so 5 years ago, maybe a year or so more than that, before COVID, every grant you would read, every paper that you would read about triple-negative breast cancer started with, triple-negative breast cancer is an aggressive disease for which there are no targeted therapies. Chemotherapy is the only option. And indeed, this is the kind of trials that were underway about a decade ago. Fast forward to 2024, and this is no longer the case. So chemotherapy is no longer the only treatment option for triple-negative breast cancer. It's no longer the best treatment option. And we, in fact, have a variety of new strategies which are approved as standard of care and fortunately available to our patients as funded by CCO, and I think in most of the provinces across Canada. So, of course, chemotherapy still retains an important role, particularly in the early disease setting and in the first-line treatment of metastatic disease, we'll see. But it's not given as monotherapy in many of these cases anymore. It's given ideally in combination with immunotherapy, PD-1 or L1 checkpoint blockade. Those are the data that we'll mostly focus on today. In addition, we have other targeted therapies, so PARP inhibitors, which are approved for people with TNBC who have germline BRCA mutations. And most recently, sort of pushing chemotherapy out of the way, is topoisomerase inhibitor 1 payload antibody drug conjugate. So this includes 2 ADCs that are approved in the metastatic setting, one specifically for TNBC, which is sacituzumab govitecan, an anti-TROP2 ADC, which does not depend on any biomarker of TROP2, and the second being trastuzumab deruxtecan, which when we think of HER2-low disease, we're mostly focused on ER-positive disease, but patients with ER-negative breast cancer were also included in the pivotal study that established trastuzumab deruxtecan for HER2-low breast cancer. And so TNBC patients, those who are HER2-low, ER-negative, are also in principle covered by the approvals for TDXT. So that's a menu of options that we have today. And recognizing that this is no longer a diagnosis of exclusion where we just simply give people chemotherapy, there's a more sophisticated approach to the diagnosis of TNBC and to the consideration of these theranostic markers, right? What markers do patients have in the metastatic setting that impact the selection of therapy? So this is actually updated now 2024. It looks exactly the same. An ESMO guideline, which largely recapitulates what we would do in Canada in patients with metastatic TNBC. And so there are several critical steps here, which of course depend on all of you, right, our pathologists, to make sure that we have the right diagnosis. Number one, of course, confirm that the patient has breast cancer, but also to diagnose triple-negative breast cancer. So I think you're probably all familiar, of course, with the ASCO-CAP definition of ER less than 1%, PR less than 1%, HER2 neu negative. With the advent of that HER2 low disease, right, simply this means not HER2 positive, so IHC 0, 1, or 2, and FISH negative. But critically, and evolving just over the last couple of years, has been the expanded eligibility of TNBC therapies for patients with hormone receptor low disease. So this is usually defined as ER 1 to 10% or PR 1 to 10% or both, where while all of these clinical trials of TNBC that have been performed that resulted in the current approvals use the ASCO-CAP definitions, and in fact, many of them still do, there's been a recognition that ER-low disease behaves like triple-negative breast cancer. In many cases, it has the molecular characteristics. If you look at something like PAM50, the gene expression profiles of basal-like disease, and it does not respond well to endocrine therapy. And as a consequence of this, there's been a recognition over the last 6 or 12 months that the treatments that have been specifically approved for triple-negative breast cancer should be available to patients with ER-low disease that's anticipated to behave in a similar manner. And so we've fortunately been able to access those treatments initially for metastatic disease, and now for the neoadjuvant setting, as we'll talk about, where we have TNBC-specific therapies, that is immunotherapy or sacituzumab govitecan as an antibody-drug conjugate, that are relevant. And as a clinician, we just need to make a decision, are we going to treat this patient as triple-negative disease, where we have access to the TNBC therapies, or are we going to treat them like ER-positive disease, where we have access to a different type of therapies? We can't go back and forth. You have to choose one or the other. But in general here, we're selecting the TNBC strategy because that's what makes the most sense. So that's important from the standpoint of now the search for these subsequent biomarkers, because PD-L1 status, again, as we'll talk about, is specifically relevant for TNBC, but now is also relevant for those patients who are adjacent to TNBC, i.e. ER-low disease. So in the past, we would have only requested PD-L1 staining on someone who is truly ER0. Now those cases with ER1%, ER9%, ER less than 10%, we would also typically request PD-L1 testing. And why are we requesting PD-L1 testing? Well, in Canada, because of the availability of pembrolizumab, which we use in combination with chemotherapy in PD-L1 positive disease in the first-line setting, where this has been shown to improve event-free survival and overall survival. So how did we get to this current treatment landscape of pembro plus chemo? It started, of course, with early studies in the phase 1 and phase 2 trials, which looked principally at immune checkpoint blockade monotherapy. So this was a study, KEYNOTE-86, phase 2 trial of pembrolizumab monotherapy in advanced metastatic triple-negative breast cancer. Here, a first-line cohort, which enrolled patients with PD-L1 positivity, CPS greater than 1. And we'll talk about some of the different definitions. And what you can see here is that most patients don't respond. You see that curve on the left falls off very quickly, but some patients do appear to benefit. And a small proportion of patients, 10, 15%, have durable benefit from this treatment. And in fact, we enrolled one of the 80 or so patients on, well, we enrolled several, but one of the 80 or so patients enrolled on KEYNOTE-86 was a patient who I treated, who 5-6 years later has been off of all therapy and has no evidence of metastatic disease when she had very aggressive symptomatic disease at the time of her presentation. And those are certainly the types of responses that historically were not observed with chemotherapy. So for a small number of people, it can truly be transformative. Of course, with these small response rates, this strategy was not pursued very much beyond this phase 2 setting, but the conclusions, as noted, were drawn. There's some activity in a minority of patients. These can be durable. PD-L1 status, line of therapy, and some other clinical features associated with response. And the treatment's generally well tolerated, as is the case with most PD-1 or PD-L1 inhibitors. So there's obviously a large body of work suggesting that chemotherapy or other direct cell-acting therapies may be immunogenic, and that combination of those with checkpoint blockade could have enhancing effects. And of course, this is also aligned with the fact that chemotherapy was the standard of care treatment in this population with higher response rates. So a number of studies were undertaken to evaluate the combination of chemotherapy with immunotherapy in the first-line setting. And so this study, Impassion 130, which was a study of atezolizumab, so a PD-L1 inhibitor, in combination with Abraxane, nab-paclitaxel, was what led to the first approval of immunotherapy in triple-negative breast cancer. It's no longer a treatment that we use, and in some jurisdictions like the FDA, this approval has been withdrawn, and I'll briefly sort of tell that story. But this was different than the treatment that we're currently using in it being a different drug, as well as it being a different biomarker. So I'm not sure if you can see my pointer, but here the biomarker that was evaluated for the PD-L1 correlative biomarker was IC status using SP142. So this was looking at the percentage of the histology that was positive, or surface area of the tumor that was positive for PD-L1 using SP142. And what this study showed is that the group of patients who got atezolizumab in combination with nab-paclitaxel had longer survival numerically. You can see here the survival in the PD-L1 positive group was 25 versus 18 months. Because of the statistical design of the trial, this was not statistically significant because the progression-free survival was not positive. So this was not actually formally tested. But based on this numerical advantage, where you can see a difference with the addition of Abraxane, it did result in approvals in the EMA, in European Union, in Canada, and by the FDA. And so it was used for a period of time here. It remains an approved therapy by the EMA. However, in North America, the FDA in particular, it is no longer the case because there was a confirmatory study that was required based on that, again, complicated statistical feature, which looked similar, except that it used solvent-based paclitaxel instead of that nab-paclitaxel. And the results of this study were convincingly negative. So here's the progression-free survival in the PD-L1 positive population, and you see no advantage of the atezolizumab there. And similarly, in the overall survival, no advantage of the atezolizumab. And so that resulted in, from a practical standpoint, in Canada, fortunately, no need to consider the SP142 biomarker and the use of atezolizumab. At the same time, and for a brief period of time, we had these sort of two competing immunotherapy regimens, because this trial, KEYNOTE-355, which is the basis of our current use of chemotherapy and pembrolizumab in the first-line setting, was conducted. So this was a similar design phase 3 trial, which took chemotherapy, a few different regimens that were used with or without pembrolizumab, and evaluated progression-free and overall survival, and also evaluated PD-L1 tumor expression, here using the combined positivity score, using 22C3, so the standard Merck assay. And the study was actually initially stratified by CPS greater than or less than 1, although partway through the study, before any results were available, this was amended, and as we'll see, the primary correlative endpoint used was CPS greater than or equal to 10. And I think, as you'll be familiar with, this is the cut point that's now used as our biomarker for pembrolizumab in clinical practice. So these are the patients, again, all first-line metastatic triple-negative disease, ASCO-CAP, TNBC, ER less than 1. You can see the PD-L1 positivity at the different thresholds of greater than 1, 75% of patients, greater than 10, just over a third of patients, close to 40%. Those are broken down here. So that 40% of patients with CPS greater than 10, which is the population where this regimen is clinically relevant, and those 60% here, for which this is not a standard treatment that we use. And the reason why, again, the clinical cutoffs are set at 10 is as following. First of all, this was the number that was used as the integrated biomarker. And what was observed in the CPS 10 or greater group is that pembrolizumab and chemotherapy extended survival as compared to placebo and chemotherapy. This is the greater than 10 group. You can see quite a significant increase in the median overall survival. And also here on the right-hand side, this sort of raising of the plateau in those patients who have durable long-term benefit. We also participated in this study. I have 2 patients who were treated on this study 5, 6, 7 years ago now, who likewise remain disease-free after many years of treatment and off of all treatment currently. So again, when it works, it can work very nicely. In the intent to treat population, so this is including those 60% of patients who were PD-L1 less than 10, we can see a much lesser degree of benefit. You're basically averaging out the benefit that's seen in CPS 10 or greater with the group who do not have benefit. And in fact, when you look at those different cutoffs, so CPS of less than 1 here, no benefit of the immunotherapy, and CPS less than 10, no benefit of the immunotherapy. So really, it's all that benefit is in the CPS greater than equal to 10 group. coincident with the integral biomarker. Oops. Again, it's important to think about the biomarker for these treatments because it's not treatment obviously has costs and also causes some immune-related toxicities. In the metastatic setting, these toxicities are largely well tolerated in that they're not serious for the vast majority of patients. The most common toxicity is hypothyroidism. The other more serious immune-related toxicities in advanced disease here are fortunately quite small, so on the order of a couple percent, things like pneumonitis or colitis, et cetera, and usually quite manageable with now standard clinical approaches. So these studies in metastatic triple-negative breast cancer have delivered a number of answers, and these clearly influence our clinical practice today. We know that the addition of immunotherapy to chemotherapy improves outcomes for some patients, and that PD-L1 expression is a clear determinant of benefit. So here, using the appropriate assay and cutoff for the treatment is critical. Again, we only use pembrolizumab, and so the only assay that's relevant for that in breast cancer is 22C3 with a CPS cutoff of greater than or equal to 10. And using this treatment, we can observe long-term disease control in some individuals. We don't know exactly how to identify those individuals. Of course, it would be very nice to be able to do so, and that the combinations with chemotherapy are tolerable. And there's now, as I noted, Health Canada approved and funded availability of pembrolizumab in this first-line setting in this population for a couple of years now. There's a number of questions which we don't have answers to. So what's the impact of the chemotherapy backbone? There were a few different types of chemotherapy that were used there. It's not clear which is ideal. Ongoing studies have now been evaluating immunotherapy in combination with antibody drug conjugates, which are highly active, as I noted. And whether or not there's other ways to identify those who benefit is not clear. We also don't really know whether the chemotherapy drives synergy here with immunotherapy or whether you simply have a population of patients who benefit from immunotherapy, and of course the rest of the patients who benefit from chemotherapy, and you put the two together and 1 + 1 is more than 2. But nevertheless, this is clearly entrenched as a standard first-line regimen. So this metastatic triple-negative breast cancer landscape, again, where we now routinely use this in the first-line setting and request testing accordingly, has occurred in the setting of a rapidly shifting landscape for the treatment of early triple-negative breast cancer and metastatic breast cancer. So in metastatic disease, we have multiple new therapies. We need to consider these biomarkers. We need to consider the diagnosis of TNBC so that we can access these active therapies. And the complexity and intensity of treatment, both with the immunotherapy and with these antibody drug conjugates has complicated things. But early breast cancer has also shifted quickly with the use of more neoadjuvant therapy, of course, and post-neoadjuvant therapies based on residual disease. And increasingly, we're seeing patients who, because they have more adjuvant therapy, recur with short treatment-free interval. And this is also a challenge where these studies in the first-line setting required a minimum treatment-free interval of 6 months. So 6 months from whenever the patients that had their last adjuvant component of therapy to when they recurred, and with a shorter time frame was excluded. And those same exclusions apply now to our standard use of these in practice. So it's not only the type of disease and the biomarker, but it's also the clinical trajectory that those patients have had that determines whether and if they are eligible for this first-line immunotherapy setting. And I've already highlighted about the diagnosis of TNBC. So what about the early line setting? So very quickly, in fact, even before we had the definitive results for these metastatic studies, immunotherapy was being tested in early breast cancer and with a focus on early triple-negative breast cancer, with the idea that the benefits of adding immunotherapy to chemo might be even greater if given in early disease, and also building upon what was recognized about pathologic complete response as a surrogate endpoint in triple-negative breast cancer. So incorporating PCR and event-free survival as key endpoints in these earlier treatment context, adjuvant and neoadjuvant. So the first study that evaluated this was the addition of pembrolizumab to chemotherapy in the I-SPY 2 trial. Again, complicated trial, but includes patients with all subtypes. The immunotherapy here was focused on the HER2-negative patients. Here you can see the triple-negative breast cancer in the hormone receptor-positive group. And those who had control, which was here like taxane-based chemotherapy, you can see pathologic complete response rates here, 13 and 20%, which essentially tripled with the addition of pembrolizumab. And so this was, they have a complicated way to model the likelihood of superiority in a phase 3 trial, and that likelihood is high in both. And studies were undertaken in both triple-negative and hormone receptor-positive disease to evaluate the addition of pembrolizumab to standard chemotherapy. So this study, Keynote 522, a study of patients with triple-negative breast cancer who have at least clinical, at least 2 centimeter tumors and/or node positive, who were enrolled and treated with either an aggressive chemotherapy regimen. You can see the chemo here, with or without pembrolizumab, with dual primary endpoints of pathologic complete response at surgery and event-free survival, as well as overall survival being collected. Importantly, you see here that N3 patients were ineligible. That's because of the co-primary endpoint of pathologic complete response and the need to have resected disease to be able to evaluate them. And here PD-L1 was also collected for an assessment as a correlate of the benefit. So this is a group of patients who were enrolled. You can see their tumor sizes and the nodal positivity. Here you see PD-L1 positivity. This is at the CPS 1, greater than 1% or greater than 1 cutoff. And here it's over 80% of tumors had CPS greater than 1 in this early line setting. So the initial results that were available were PCR at this interim analysis, and you can see that overall PCR rate was increased from about 50 to about 65%. This difference was a little less pronounced at the final analysis because the control group, when all the patients were accounted for, performed a little bit better, but overall about a 10% improvement in pathologic complete response. And that effect was observed irrespective of PD-L1 positivity at that CPS 1 cutoff. So you can see in the positive group, again, comprising 80% of the patients, you see about a 15% increase. And in that minority of the patients who are PD-L1 negative, less than 1, you still see an incremental improvement in pathologic complete response. So the rates are lower in PD-L1 negative disease. So PD-L1 is clearly a marker of sensitivity to the regimen, but the benefit of adding pembrolizumab is present irrespective of PD-L1. And beyond those PCR data, the event-free survival has also read out positively. So here we see event-free survival, which is mostly comprised of distant recurrences, so obviously lethal metastatic disease. And we can see here an improvement of about 7 or 8% in event-free survival, which is subsequently translated into an improvement in overall survival. So again, a treatment that has sort of hit each of its endpoints and has now been integrated into our standard management. You can see here that unlike in metastatic disease, the PD-L1 status did not impact the benefit of pembrolizumab. And so we do not use PD-L1 to decide which patients with triple-negative breast cancer are eligible for neoadjuvant pembrolizumab. We think about how this changed the pathology of the disease, or the beyond just the binary pathologic complete response rate. Here's RCB as was assessed in the trial. You can see, of course, there's more pathologic complete response. These are the final numbers, like I said, a little bit closer together, but still an increment in RCB 0. And you see less of each of the amounts of higher residual disease. The other interesting finding is that we use RCB, and we love it when our pathologists take the effort to calculate RCB because we know it's prognostic. Interestingly, it remains prognostic in these patients treated with pembrolizumab. But what you'll note is that patients who have RCB who received pembrolizumab in the neoadjuvant adjuvant setting actually have a much better prognosis than the patients who get to RCB with just standard chemotherapy. So this modifies our ability to estimate the risk of patients who do not have a pathologic complete response, i.e. those who have residual disease. RCB appears to be associated with not quite as bad as a prognosis as it historically was when we were using chemotherapy. Of course, now we use capecitabine in the adjuvant setting, or olaparib for those who have germline BRCA mutations, who have residual disease. In this study, neither of those two things were allowed. So hopefully the outcomes that we see for these patients with residual disease today are actually better than shown here. Although, of course, patients with RCB3, fortunately a minority, still have dismal outcomes with very high recurrence rates. Also, the RCB is interesting because when looking at the type of events that occur, we see differences based on the amount of residual disease. And interestingly and notably, in those patients who either have a pathologic complete response or have just a small amount of residual disease in the breast and lymph nodes at the time of surgery, RCB1, we see a preponderance of brain-only metastatic disease, which probably reflects the fact that, again, these treatments don't get into the CNS very well. And so when there is disease present there, that's the kind of thing that can recur. We've been successful in eradicating the systemic disease in these patients with RCB0. And so there's a greater weight of brain-only disease. Whereas RCB3 is on the other end of the spectrum, we have a lot of local recurrences that occur there. Again, we think very carefully about using this treatment because it's associated with quite a lot of immune-related toxicities. It's a tough regimen to give. And when we're curing most of the patients who receive this, it's important to recognize that many of these immune-related toxicities can be lifelong. So summarizing the early TNBC, we've now seen from several trials. I didn't show you all of them. I just showed you the pivotal one that resulted in approval. The other were not registrational trials. That outcomes are improved with immunotherapy added to neoadjuvant chemotherapy, including the improvement in overall survival. This appears independent of PD-L1 status and has resulted in a standard of care consisting of neoadjuvant chemotherapy with neoadjuvant adjuvant pembrolizumab. Again, making the diagnosis of TNBC on these diagnostic biopsies critical, again, expanded into that ER low population now with our availability. There's a number of, again, key questions that we don't really understand, and hopefully these may be further elucidated. There's actually going to be some correlative results from Keynote 522, this study I just described, that will be presented at San Antonio next week. We also don't know the role of adjuvant pembrolizumab in this population. It was given as a perioperative regimen. So we actually have this study that's ongoing currently enrolling at our center through the CCTG and the US NCI, which is evaluating de-escalation of pembrolizumab for patients who have a pathologic complete response. So instead of the standard 27 weeks of adjuvant pembrolizumab, randomizing them to observation. So just touching very quickly on ER-positive breast cancer, I showed you from these I-SPY data that there was also this improvement in pathologic complete response rate, albeit less common, as we expect in hormone receptor-positive disease. These are all patients who have MammaPrint high, so we think of it as like high-grade disease, where there was an improvement in PCR rate with the addition of pembrolizumab. And so a couple of studies have been done, a third one's underway, in this high grade. So this is specifically grade 3, ER-positive, HER2-negative disease where pembrolizumab was again added to chemotherapy, similar design, slightly different chemotherapy, similar endpoints looking at pathologic complete response rate and event-free survival, and also looking at PD-L1 status as stratification factors. Patients had a bit higher anatomic risk disease to justify the use of immunotherapy. It included patients with ER low, so 5% or so of the patients had ER low disease. They all had centrally confirmed grade 3 disease. And so far, we have the PCR endpoint of the study, which did show an improvement in the pathologic complete response rate with the addition of pembrolizumab. Here you can see in the all-comer population a delta, which is actually very reminiscent of what was observed in TNBC, starting from a lower number, and looking at some additional PCR definitions here. This, you can see here, shown here, that benefit of pembrolizumab for the PCR endpoint is not dependent on CPS when using a 1 threshold. You can see both groups appear to have some benefit. However, for the ER less than 10 group, we can see that the difference in PCR numerically is substantially greater. So ER less than 10% rate, the PCR goes from 30 to 55%. So this is not driving the overall effect, but obviously is a huge effect in that ER less than 10 group, and is one of the motivating factors that's caused us to adopt this regimen in ER low patients. So another study of nivolumab, so another PD-1 inhibitor, conducted in a similar way. What they did, however, was look at PD-L1 using IC, using SP142. And interestingly, what they observed using this assay in this study, which was not registrational, it was a randomized phase 2 trial as a result of some modifications that were undertaken when enrollment was slow during COVID. You can see that in this study using this assay, where about 40% of patients are positive, or what is this, 2/3 of patients are positive, sorry, 1/3 of patients are positive, that all the benefit appears to be in the PD-L1 greater than 1% rate. So whether or not there's some additional analyses that are undertaken from Keynote 756 as a consequence of this remains to be seen. And of course, we're waiting for the event-free survival endpoints before there's any adoption of immunotherapy in ER-positive disease, where we don't have quite the same strength of a correlate between pathologic complete response and event-free survival. So summarizing quickly here from this high-grade ER-positive, again, this is only high-grade disease. A couple randomized trials and the I-SPY 2 suggested that PCR is improved with the addition of immunotherapy. We need these EFS data. This will take another year or two, probably a couple of years. The role of PD-L1 status remains a bit uncertain for ER-positive disease. For those ER less than 10 group, there's a large magnitude of benefit that likely behave like TNBC, and we can now use immunotherapy like we can use it for the TNBC cohort. And for the more strongly ER-positive patients, the adjuvant landscape has shifted a lot with the use of adjuvant CDK4/6 inhibitors, which again, I know you guys know all about thanks to our request for Ki-67 testing in that group of patients. So a few things to shake out from the therapeutic landscape. As a consequence from all of these, we have these funding algorithms that are determined by CADTH and then flow down through the provincial cancer agencies, where basically for patients with triple negative or ER low breast cancer, regardless of CPS, we have access to pembro and chemotherapy. We use PCR residual cancer burden to decide what we're going to do in the adjuvant setting. Interestingly, we cannot combine pembrolizumab with other agents because of the way that it's been approved by Health Canada. In the metastatic setting, PD-L1 positivity using CPS, as I've noted, is crucial to our treatment decisions. And this is impacted a little bit by the prior treatment that they've had, where we use 6-month treatment-free interval as a decision point to, number one, determine eligibility for pembrolizumab, and number two, to decide about retreatment. Although we, of course, have no data to support the use of pembrolizumab in the metastatic setting in patients who received it in the adjuvant setting, because Keynote 355 was done before there was any availability of such therapy. So these just summarize what I've highlighted briefly. I think critically here, only chemo is no longer true for triple-negative breast cancer in 2024. And really, this management requires integrated multidisciplinary care with pathologists like yourselves. And we're thrilled to have your engagement and collaboration in the management of this disease, for which we've made great improvements over the last decade in improving outcomes, but still have work to do. And fortunately, there are additional clinical trials which will hopefully help us achieve that together. So I'll stop there, and any questions, happy to take them.
I have a question.
Hi, sure. Sharon?
Yes, hi. Thank you for your talk. So as you know, the cutoffs for different markers get revised all the time. Do you foresee the CPS cutoff being revised, like maybe towards maybe lower?
So probably not. The data from Keynote 355, which looked at it's separately looked at the 1 to 9 group and showed that there was no benefit in that group. Now,
Okay.
10 is an arbitrary thing, right? Whether it's 8 or 5 or 7, who knows? And
Mhm.
there probably are some patients, right? We know that even in studies because of some studies that included patients with PD-L1 negative disease, like the earlier phase 2 trials, or because of heterogeneity or whatever. We know there's discordance, that there are some patients who have PD-L1, which is less than 10, who probably benefit. Who those individuals are, we have no idea. But my general approach is, if I can find a sample that has PD-L1 positivity, like at 10, at the threshold that we need for funding, in someone with metastatic triple-negative breast cancer, I want to give those people a shot at immunotherapy, because however long that shot is, it's the one shot at potentially achieving a long-term, durable disease control, potentially cure. And the addition of pembrolizumab for the average patient adds no toxicity. Most patients don't have toxicities from pembrolizumab. So obviously there are cost implications from a systemic perspective, et cetera. But if there's PD-L1, like I'd much rather have a PD-L1 of 10 than a PD-L1 of 9.
Okay, yeah, fair enough. Obviously, those cases are really hard, the ones that straddle the 10.
Yeah.
I think one would be easier, but as you said, clinically, it
Yeah,
makes
so I don't think that there's going to be a revision until or unless there was different clinical data in the metastatic setting. And the studies now, like the ongoing suite of studies that are focusing on chemo and ADC, are all using PD-L1, like CPS 10 as well. So it's unlikely to change. I think what could change, certainly in the early disease setting, it's possible there could be some changes motivated by the hormone receptor positive disease or hormone receptor positive disease in the advanced setting as well, where we don't currently use it. And there are efforts to develop, other immunotherapy combinations, like other checkpoints or whatever beyond PD-L1, and these may explore, other cut points besides CPS1.
Okay, thank you.
Rachel?
Hi, thank you so much for the very useful talk. So as we start, it looks like we're going to be seeing more use of pembrolizumab and other agents in the neoadjuvant setting. So is there any information regarding whether these patients, if they later recur or if they metastasize, are they then also eligible to receive pembrolizumab again? Is there a sort of max exposure or a dosage for that? And if they recur again, are we testing these secondary sites for PD-L1?
Yeah, so good question. So if patients recur with a treatment-free interval of greater than 6 months, so whenever their last treatment, because they get adjuvant pembrolizumab, that goes until 27 weeks. So it's like 9 months or so after their surgery when they would finish the pembro. So then they need to have another 6 months beyond that before a recurrence occurs to be eligible for the pembro. So it's sort of recurrences beyond a year or beyond a year and a bit. They are eligible for reconsideration of those treatments. It does require PD-L1 positivity. There's no specification on what tissue needs to be PD-L1 positive to be eligible for treatment in the metastatic setting. In the study, probably half of patients had archival disease from the breast, or many of these patients had de novo metastatic disease in the trial, actually, and so had a breast biopsy as the tissue that was tested. What we do know is that PD-L1 positivity is lower on liver metastases in particular. And when we're thinking about sites to biopsy for patients with metastatic disease, liver is one of the most common sites of metastatic disease that we go for, that you guys evaluate for us, just because it's easy to biopsy, right? It's compared to lung metastases or other things. So we tend to do a lot of liver biopsies to confirm metastatic disease. Those probably systemically, reduce the proportion of patients who would be eligible for immunotherapy because their primary archival tissue might have been PD-L1 positive, whereas their recurrent disease may be PD-L1 negative if it comes from the liver. So there's no, any tissue can be tested. There is this requirement of at least 6 months. Those patients are eligible, and there's no concerns around, cumulative toxicities from the treatment. Patients who have tolerated in the past probably tolerated it, as well or better if retreated with it, because you've kind of hived off the group of patients who exhibit immune-related toxicities in the first place.
Thank you.
So if there's no other questions, I know you guys will get into some.
Sorry, I think there's another raised
Oh,
hand.
sorry, I can't see. Yeah, go ahead.
Sorry,
Okay.
sorry, my question was just
Pratibha
about.
will start. Yeah.
Oh, sorry. I just had a question about the ER low positive. Like, I think it's good that they're included in the trials now, because we were getting a lot of practically we're getting a lot of requests to retest things that were called ER
Are
low.
you sure that's 1%?
Yeah, but my question is, like, it makes me wonder if the old 10% cutoff was actually valid, because where do those ER low percent go? Like, so if they're being included in the triple negative trials, is there really an ER low percent that was, because we were told that you're trying to identify these patients in order to give them a chance with
Of
endocrine
endocrine
therapy.
Yeah.
Yeah.
Yeah, the
But it
reality
seems
is
like
that those,
most oncologists don't treat them.
yeah. So, in the adjuvant setting is a different story, right? If someone has ER 10% and we can give them adjuvant tamoxifen for an aromatase inhibitor or something, and, this might lower their risk, it's an easy thing to do. In the metastatic setting, it's an easy thing to do if you're not doing it to the exclusion of something else, right? And so I think now that it would be to the exclusion of something else because we have effective therapies for TNBC, it's a different calculus. And similarly in the metastatic disease, in fact, many of the modern studies of ER positive disease in the metastatic setting or adjuvant setting, they've actually used they have maintained that's greater than 10% cutoff. So the ER less than 10 people, if you don't treat them like TNBC, are this kind of orphan population. They appear to benefit from all the treatments that we have for TNBC. And so, I'm grateful to no longer have to request reappraisal of ER 1%. That said, they're not included in all of the current clinical trials. There are some studies that include ER low. So like our current neoadjuvant studies that are evaluating antibody drug conjugates and immunotherapy in the neoadjuvant settings allow ER low. The metastatic trials do not. So the first line metastatic trials of ADC plus chemo versus standard of care, which is chemo and pembro or chemo alone, have not adopted that. And part of it is because of the labels, like the FDA label for pembrolizumab in the metastatic setting is based on ASCO-CAP. And so as a control arm, it's sort of fixed there. So I think that there's been pretty widespread agreement across the clinical, like medical oncology community over the last 12 months, 12 to 24 months, that ER less than 10 needs to be reappraised. And, whether that happens officially or not, it's certainly happening in the clinical landscape. And as supported by our funders who often are very dogmatic about their approach to the evidence. So this is a nice place where they've exhibited some flexibility. Was there any other question? Or Sharon, did you have your hand up?
I had, but I think that we are behind schedule, so maybe we will go move forward with our case presentations. It's okay.
Yeah, no, of course. Thanks for your engagement and thanks for having me here today. And again, thanks for supporting all of our efforts to deliver these treatments.
Right. Thank you very much. Thank you so much for your very informative lecture today. So we'll, as Sharon mentioned, we will go ahead with our first presentation. So I'll hand it over to you, Rachel.
Thanks so much, Jessie. Let's see here. So thank you so much. Hopefully you could see my full screen now. So my name is Rachel. I am a breast pathologist at Sunnybrook Health Sciences Center. Excuse me, that's my phone. And very excited to join as a co-organizer of Breast Community of Interest. Today, I won't be going over one specific case, but I'll just go over breast PD-L1 testing in the setting of triple-negative breast cancer. Just a very quick overview, and then we'll have a quick time for questions following that. So at the current time, we are assessing triple-negative breast cancers with PD-L1, the 22C3 PharmDX assay. And this assay requires a combined positive score, which uses the number of PD-L1 positive staining tumor cells, as well as immune cells, including lymphocytes and macrophages, over the total number of viable tumor cells multiplied by 100. So a few caveats and notes to make of CPS scoring. The assay requires a minimum of 100 viable tumor cells for evaluation. So it's a very important note, especially when we're looking at metastatic cancer specimens that might have a lot of necrosis or crush artifact, things like that. And a reminder that the way that positivity is defined for PD-L1 score is different whether you're assessing a tumor cell versus an immune cell. So if we are looking at tumor cells, any perceptible and convincing partial or complete membrane staining would be considered positive. However, if we're looking at immune cells, so the tumor-associated lymphocytes and macrophages, this positivity is defined by any membrane and or cytoplasmic staining of these cells. So the difference being that cytoplasmic staining is allowed in determination of positivity for immune cells, but not for tumor cells. So this is from the 22C3 PDL1 manual. Here are some examples of positive staining for tumor cells. So these arrows are pointing to tumor cells where there is partial linear membrane staining. So this is allowed to be called positive. Another example here of granular membrane staining. So that is partial in a lot of cases here too. So this again would be considered positive staining for a tumor cell. And then this is an example of immune cells, which are not really having good membrane staining, but a lot of areas with cytoplasmic staining. So these would be considered positive for the numerator of CPS score. And then I just want to show a few images of PDL1 that was near that 10% or 10 score cutoff. So this is an in-house case that we assessed here at Sunnybrook. So this is a poorly differentiated invasive carcinoma, and then there are a few scattered stromal immune cells here as well. So again, so these are only 20x snapshots of the tumor. So overall, the scores rendered for these are of the overall assessment of the whole tumor, but I also tried to screen grab the areas that I think are also near a 10% cutoff. So here, in my opinion, there's a lot of small immune cells that have cytoplasmic staining, and then a few tumor cells that have staining that for me was convincingly membranous. So this is an example. Again, this is just a portion of it, but overall where near 10 score was called positive. This is another example of a poorly differentiated triple negative breast cancer with scattered immune cells. Apologies, it didn't scan very well, so it's a little bit blurry. But again, in this case, we see a lot of the tumor cells having some convincing membrane staining, and then some of the immune cells in the stroma having some cytoplasmic staining as well. So overall, this was an example of a near 10, again, CPS score of positive. It was a bit difficult to find some near 10 negative cases, so I pulled these images from the CBQA PDL1 module for triple negative breast cancer, and this module is available for everyone. So it includes a lot of really good cases that are sort of the near cutoff score that we can practice with. So I left the URL there for your use as well. But this was an example per the manual that was a near threshold, so near 10. However, they considered this case as negative. So it's as you can see, there's a lot of overlap with the prior cases I showed that were sort of called near 10 positive. In this case, I think a lot of the staining that we're seeing is cytoplasmic staining in the tumor cell. So I think if you look at it quickly, it looks like, oh, this looks like a case that would be near 10 positive, but looking very carefully, it's mostly cytoplasmic in the tumor cells, which we're not counting. And then this is the last case I was going to show, again, from the CBQA module of a near 10 negative case. So again, looks like from first glance, very similar to the cases that we called near 10 positive. But in this case, again, I think a lot of the tumor cell staining is actually cytoplasmic without clear membranous staining as well. So overall, this was considered negative. And then a quick note of current funding for PDL1 testing in Ontario. So we're testing PDL1, as mentioned by Dr. Cescon, in metastatic or locally recurrent unresectable triple negative breast cancer. In terms of tissue selection, primary and or metastatic tumor is eligible to be tested pre or post-treatment if they've had neoadjuvant therapy, but we're not testing cytology specimens or decalcified specimens. So if there are any questions, we could take them now before we move on to the case presentations.
I actually have a quick question. How
Yes.
often do you kind of just do like a ballpark reading, and how often do you actually count cells?
Oh, that's a very good question. I
yeah.
would say counting cells, I would definitely count all cells or all cases that are sort of the near 10. And then anything where there's staining that's where the tissue's like not completely blue kind of thing, where I know it's negative for sure, I would do counting. And another thing, you know, of course, any case that's near 10, I would advocate sharing it with a colleague and getting consensus for those cases, since it's such a big impact in patient management.
Yeah, I wonder, following the lecture that we've just had, and seeing how oncologists really want to give this drug, if that would kind of skew our scoring as well. Because if we know that that's what kind of they want and that's giving the patient a chance, then
yeah,
obviously it's going to be much harder for us to call something near 10.
Right.
You know,
It was a
10,
memorable
right?
thing. I think Dr. Cescon, he said, I would much rather a patient be a 10 than a 9. So
Right. Anyone else that's got a question at the moment? If not, you can.
I actually am wondering what are the institutions that are currently testing PD-L1 around Toronto in-house? So obviously UA Gents and Mike's, Sunnybrook and Sinai, and any other institutions that we know of? Maybe people who are here on the call can just say something in the chat. Okay, so many are not responding, maybe not testing or shy.
All right, Rachel. So thank you. Do you have other slides to present?
nope, those are my examples that I was showing. Yeah.
All right. Well, thank you very much. That's a very nice nice presentation to follow on from our lecture here. Okay. So next we'll move on to the next presentation from Dr. Omar Alzala. So would you like to start?
Yes, I will share my. First, thank you very much for opening this opportunity to share interested cases in breast pathology. My name is Omar Al-Zallal. I am from Saudi Arabia, Assistant Professor of Pathology in College of Medicine, King Faisal University in Saudi Arabia. And I am a fellow in breast and gynecology pathology at King Abdulaziz Medical City. Okay, I will start with the case. This is a case of a 61-year-old female, not known to have any medical illnesses, complaining of breast pain for 1 year, secondary to breast mass. The mass located in upper inner quadrant. The mass is not increasing in size since a year. There is no family history of malignancy. The breast image reporting and data system, BIRAD category 4A, low suspicious. Pelvis, abdomen, and lung CT scan were done for malignancy workup, and all were negative. The procedures done for this patient, core needle biopsy, then lumpectomy. First, because the histology of the core needle biopsy and resection almost similar. I will start with the gross picture. Here is the lumpectomy. The lumpectomy was sliced to many slices. This is some of the slices. As you can see here, there is a skin and the adipose tissue, and there is a mass. The mass is fairly circumscribed, gray whitish in color, having some punctate of hemorrhage with no visible necrosis. There is acetylate nodules just adjacent to the main tumor, separated by the fat. And the tumor is pushing the skin, but not infiltrating, which confirmed later by histology. The mass measured 3.5 centimeter in greatest dimension. Here is the core needle biopsy. As you can see here, this is the tumor cells From this power, it looks hyperchromatic, very dark cells, spindly, and biliomorphic. There is a variety of sizes and shapes. The background stroma is myxoid stroma. If we go higher, there is hyperchromatic spindle cells in eosinophilic cytoplasm. The tumor cells having a fairly tapered end of the nuclei. And there is bizarre looking tumor cells and some mitosis. Here another photos. We have here hyperchromatic in eosinophilic cytoplasm. Some bizarre looking tumor cells, all floating in myxoid background. The resected specimen or resected histology showing this is the epidermis, dermis, and the tumor located in the subcutaneous. The tumor looks fairly circumscribed, pushing the dermis. And from this power, it looks myxoid in color. Here is some nodule separated by the fat. This is the main tumor. Sorry, main tumor, and this is the satellite nodule. The satellite nodule showing same morphology of the tumor cells, the spindle hyperchromatic malignant cells, but the stroma is less myxoid and more to collagenized stroma. Here is another photos. The tumor cells arranged in intersecting fascicles, hyperchromatic, with the eosinophilic cytoplasm, some bizarre looking cells, and spindly. The immunohistochemistry showing negative for ER, PR, SOX10, GATA3, CD34, beta-catenin, S100, pancytokeratin, myogenin, MyoD1, P63, CAM5.2, all negative. But for the SMA, H-caldasmin, and Desmin, all positive. Here the Ki67 showing 40 to 60% of proliferation index. The diagnosis on core needle biopsy was myxoid smooth muscle neoplasm and deferred for the resection. The final diagnosis for the resected specimen is myxoid leiomyosarcoma. Leiomyosarcoma is a malignant tumor with the smooth muscle differentiation. Primary leiomyosarcoma of a breast are rare, accounting for less than 1% of all breast neoplasms. Most patients are affected during adulthood in the 4th to 6th decade of life. Leiomyosarcoma affect male and female equally. The majority of cases arise superficially in the dermis, especially around the nipple areolar complex. Leiomyosarcomas arising in the deep parenchyma are rare, and most reported cases have been in female patients. The clinical features of leiomyosarcoma, which typically presents as a slow-growing, palpable mass that may be painful and tender. The etiology is unclear. Most reported cases are sporadic. The soft tissue leiomyosarcoma usually have highly complex karyotypes, and they show molecular heterogeneity overall. The origin of leiomyosarcoma of breast also unknown, but some suggest that the origin could be from smooth muscles of the lactiferous ducts or blood vessels, or from the erector pili muscle at the periphery of the areola. Microscopic appearance, cutaneous leiomyosarcomas tend to be smaller in size. It reached up to 1.5 centimeter with indistinct margins. Whereas leiomyosarcomas arising in the breast parenchyma are larger, reaching 9 centimeter in greatest dimension, and appear as well as circumscribed, gray whitish in color, sometimes fleshy, tan fleshy, associated with hemorrhage and necrosis. Microscopic features similar to soft tissue leiomyosarcomas, which composed of intersecting fascicles of spindle cells with the blunt-ended nuclei. The cytoplasm is frequently eosinophilic, but sometimes can be clear or fibrillary. Nuclear atypia, pleomorphism, and mitosis, mitotic activity are typically prominent. Tumor necrosis may be observed. Although dermal lesion may appear well circumscribed, they show at least focal infiltration into subcutaneous fat or breast parenchyma. Lesions that are completely confined to the dermis are designated as atypical intradermal smooth muscle neoplasm. Immunohistochemistry is helpful in the diagnostic process, which most tumors show expression of smooth muscle markers, but 40% of leiomyosarcomas may show reactive to keratin or EMA. In small biopsies, other tumors may resemble leiomyosarcoma, like myofibroblastoma, desmoid fibromatosis, inflammatory myofibroblastic tumors, and schwannoma. Of course, in the diagnosis of leiomyosarcoma, we have to rule out metaplastic carcinoma, especially the spindle type, which can be distinguished by the P63 and high molecular weight cytokeratin. Lastly, the prognosis and prediction of leiomyosarcomas. Cutaneous leiomyosarcoma is best treated by complete excision of the tumor. Tumor may recur and rarely metastasize. Mastectomy is appropriate for leiomyosarcoma arising in a breast parenchyma. For the mastectomy and excision in general, the recommended clear margin is 2 centimeter. Some authors prefer 3 centimeters for optimum efficacy. Metastasis to distant sites have been reported, although leiomyosarcoma does not metastasize to the lymph nodes. There is no prognostic parameters have been validated for leiomyosarcoma arising in the breast. Here is my references, and thank you.
Thank you, Omar, for presenting this very rare entity. Does anyone have any questions?
I have a question. Maybe I missed the communication about that. Was ALK1 and RB1 performed by immunohistochemistry in this case, Omar?
No,
Okay.
it wasn't done.
Yeah, I would actually say that for me, the CD34 negative status is not enough to rule out the possibility of myofibroblastoma. Particularly, we recognize a leiomyomatous variant. And I actually recently had a case that was sent to me where I favored a myofibroblastoma with leiomyomatous differentiation, and that case was a CD34 negative, and there was a loss of RB1. So in that case, I favor that. In my experience, leiomyosarcoma of the breast is very rare unless it is arising in the skin. And likewise, I would like to see an ALK1 stain in such a tumor where you have a spindle cell neoplasm with myxoid background.
The pleomorphism in our case is
Yeah, it is
too prominent.
definitely impressive. I agree, but I think that at least for completion, I would have ordered it.
Yeah.
I think I could be wrong, but I think RB could be lost in leiomyosarcomas of the breast. I'm certainly no expert on leiomyosarcomas, but
Yeah.
Omar, that was very nice. Thank you. You mentioned in your last slide that there aren't any prognostic markers of use in the breast or recognized in the breast. Do you still grade these, or is there any point in grading them?
Grading, yes, we grade according to the FNCLCC grading system, which is the histological type, the tumor differentiation, mitosis, and necrosis. Based on that, we give grading.
And what was the grade in this case?
This one, grade 2.
Grade 2.
Yeah,
and did you follow up and how the patient was managed after excision?
No, under follow-up. Also, we exclude the possibility of metastasis. That's
Right.
why we did the imaging for gynae, for the pelvis, abdomen, and chest. Actually, full body scanning to exclude any other metastasis.
Okay, great. Thank you.
Thank you.
I've got a quick question. So just to clarify, are you treating this as cutaneous or kind of breast leiomyosarcoma?
It is in the subcutaneous, actually.
Okay.
Yeah, in the subcutaneous of the breast.
Okay. So was patient offered because I think one of your slides mentioned that mastectomy was actually an option. So I was a little bit surprised by that.
Yeah.
Was that actually offered to the patient?
Sorry, I couldn't. Can you repeat the question? Sorry.
Oh, sorry. I think I read in one of your slides that for kind of leiomyosarcoma arising from the breast, that mastectomy was actually a treatment option. Is that, or did I misread that?
The treatment option is excision, surgical excision.
Just excision, okay.
Yeah. From literature, some try chemotherapy and radiotherapy with good response. Chemotherapy for the multi-targeted tyrosine kinase inhibitor, which reflect good response. But the main treatment is surgical excision with clear margins.
Right.
Omar, you mentioned that about 40% of cases can show keratin staining. So from a practical point of view, how do we, distinguish confidently, I guess, metaplastic carcinoma from a primary leiomyosarcoma? I mean, sarcomas of the breast are rare, and we always consider them a diagnosis of exclusion. Hence the broad panel of cytokeratins and P63 that we do, and we often accept very focal positivity to kind of pushes towards, a carcinoma diagnosis rather than a primary sarcoma diagnosis.
Actually, the diagnosis of metaplastic carcinoma can be rendered based on the presence of any epithelial differentiation. In our case, we processed the whole tumor. There was no epithelial elements. We did two epithelial markers, both negative, and the smooth muscle markers all were positive actually, not some. The Desmin, SMA, and HCAL Desmin all were negative. Oh, sorry, all were positive in our case. That might suggest the leiomyosarcoma. But yeah, we consider the metaplastic because sometimes the smooth muscle heterogeneity in the metaplastic carcinoma, it can be more prominent. So maybe in order to misdiagnose, we process the whole tumor, and there was no epithelial marker. Epithelial element in the tumor.
Great, thank you.
Thank you.
All right. If there are no further questions, we will move on to the next presentation by Dr. Amin Asifa from Scarborough. Yes. Yeah.
Okay. Yeah. Hi. So my name is Asifa Amin, and I'm from Scarborough Health Network. I'm a general pathologist here, and today I'm presenting a case of a 83-year-old female in whom there was well circumscribed on ultrasound. There was a well circumscribed heterogeneous hypoechoic highly vascular solid nodule measuring 2.1 by 1.8 by 1.4 centimeter, and there were no suspicious microcalcification. On the, let's just see this one. Okay, so okay, so on the low power and on high magnification, we can see there are nests which are forming tubular structure, and on this power we can see some myoepithelial cells at the periphery, and with the intervening very sclerotic collagenized matrix material surrounding these tubules. And we did, this was a biopsy. First, initially biopsy was done, and this is the morphology showing on biopsy. So we did stains for myoepithelial cells. We can see like there is a proliferation of myoepithelial cells positive for P63 and P40 with some luminal cells, unstained luminal cells. And also it did a CK56 showing myoepithelial cells. And in this case, there's just a very focal, mild to moderate, very focally positive ER. And PR is negative on biopsy case. So this was signed out as, on biopsy, it was signed out as a biphasic neoplasm favor adenomyoepithelioma, and it was sent for a consultation to St. Mike's, and the result came back as adenomyoepithelioma, and the final classification will be based on the excisional specimen to rule out malignant transformation of the epithelial and or myoepithelial component. So overall, the classical adenomyoepithelioma is a rare breast tumor and accounts for less than 0.5% of all breast tumors. And it was first described in 1970 by Hemberel. So this patient was followed by lumpectomy specimen. So the lumpectomy specimen that we had shows a unifocal, well-circumscribed gray-white nodule, and the nodule is 2.1 by 1.8 by 1.5 centimeter. And this whole specimen, the whole nodule, was submitted for microscopic examination. So on low power, we can see like there is a kind of a fibrous capsule of fibrosis around this nodule, and there is some area which shows more like a intraductal papilloma-like structure, some papillary structure, as well as areas which looks more solid. And so we look at the solid and these papillary areas. So some areas were showing similar morphology as we had seen in biopsy specimen, tubules with intervening sclerotic collagenous stroma. No mitosis or any atypia was identified in these areas. But then we went to the other area, which is showing more proliferation of myoepithelial cells. And we can see like there is quite a pleomorphic myoepithelial cells with prominent nucleoli, more open vesicular chromatin, and we can still see the luminal cells here forming some tubules, but there is areas where there's more proliferation of myoepithelial cells with also with increased mitosis. So mitosis count on the lumpectomy specimen was 3 to 4 per 10 high power field. We did the basic stains like P63 and smooth muscle myosin, again highlighting smooth muscle myoepithelial cells, and with luminal cells we can see not stained. And we did CK56 showing the similar pattern of staining as we had seen in biopsy specimen. And this specimen was also sent out to Sunnybrook for consultation. So initially I signed it out as adenomyoepithelioma with atypia, size 2.1, close margin 2 millimeter, completely excised, and the consultation report came back as atypical adenomyoepithelioma. To same measurement with the same completely excised. So in our tumor in the lumpectomy specimen, the atypical adenomyoepithelioma was diagnosed based on the histological features. So there were 2 histologic features which were considered sufficient to call it as atypical adenomyoepithelioma. So adenomyoepithelioma, when we call it as atypical, there are some features which are present, but they are not enough to call it as malignant. So features like mild to moderate cytologic atypia, mitosis could be from 3 to 10 per high power field, no or focal necrosis, tumor is usually very lobulated, well circumscribed, they can be mild with or without mildly infiltrative growth pattern. On the other hand, if we want to see some malignant features, so the features which will favor malignant, so these features can arise either in luminal or myoepithelial component. So the features which would favor malignant will be marked cytologic atypia, increased mitosis more than 10 per 10 high power field, necrosis, infiltrative growth pattern. So if we go and see how this adenomyoepithelioma is categorized. So it is categorized under classical AME, atypical AME, and malignant AME. So in classic, we can see there is usually no cytologic atypia, there is no necrosis, mitosis is less than 3, but in some papers it says that it can go from 3 to 5 per 10 high power field, but less than 10. So on the other end, again, we can see the margin of circumscribed, and for the classical one, complete excision to reduce local recurrence risk. For atypical, as in our case, we had these two features which were present in our case, so mild to moderate cytologic atypia and mitosis. So again, for local excision, for the management, complete excision with clear margin to reduce local recurrence. While on the other hand, malignant AME. So I'm going to go and show you another slide, which will categorize malignant AME into 3 categories. So we have the malignant AME in situ, malignant AME invasive, and AME with invasive carcinoma. So basically in AME in situ, so it is well defined, and in situ AME, there is more epithelial component, which is showing DCI-like features that we see, like cribriform or solid pattern with myoepithelials at the periphery. And this is usually no hormone therapy can be offered if ER and large size. And for the malignant AME invasive, it has some infiltrative, they have infiltrative border. And this component, this AME invasive, can arise from either epithelial, myoepithelial, or both. So usually these AME invasive have a it has a particularly, the architecture is dominantly more ME type architecture, but there's either proliferation of epithelial or myoepithelial component with the features of malignancy, like marked cytologic atypia, increased mitosis, and necrosis. So this category is AME invasive. While when we say AME with invasive carcinoma, so this one has a very dominant malignant component, which is arising independently with the coexistence of classical AME. So these are the 3 categories for the malignant adenomyoepithelioma. So I have, these are the a few important points that I noted, I learned during this case. And yeah, and these are my references. And thank you.
Thank you very much. Does anyone have any questions about this case?
There is a question in the chat. And so Dr. Mushkin is asking whether you included phylloides tumor in your differential diagnosis.
Initially, because it was on biopsy, it was looking like a biphasic tumor, and it was quite circumscribed, and on biopsy there was a fibrous septa around it, and there was no leaflet, like cleft-like architecture or myxoid stroma. So that was not because the biopsy was done by my colleague. So it was just signed out as biphasic neoplasm favoring adenomyoepithelioma because of the proliferation of more myoepithelial cells. So then it was sent out for consultation.
Sorry, there's another question from Dr. Jasper Tour. This is what immunostain for in situ malignant AME, if any?
So for in situ, we can do the same like myoepithelial markers, and as if there is AME with in situ, we can see like the epithelial component is showing features of DCIS. It's the epithelial component. Like we can see like there is cribriform solid architecture, could be papillary architecture, but it is confined, and there is the myoepithelial cells at the periphery. So we can do smooth muscle myosin P63, which will highlight the periphery of the in situ component.
And I actually have a question about, so you, like in one of the last few slides, you kind of broke it down into 3 different categories with the malignant AME invasive and then invasive carcinoma with AME. So I'm a little bit confused by the last category of invasive carcinoma with AME, because you mentioned that these are, it sounds like essentially independent. It's not arising from the AME, correct?
Yes, yes.
Yeah.
So there is a separate independent component of invasive carcinoma, which could be like invasive ductal carcinoma, lobular carcinoma, which arising from the epithelial. But with coexistence of AME, there is an architecture which is showing like AME, but the component, the invasive component, is dominantly separate from AME.
Right. Okay. Because I just wonder if that's the AME, could that just be an incidental finding, right? Like in the breast, you have lots of different benign entities that you can see.
Yes,
and,
yeah.
And so why are we making that distinction of having invasive carcinoma with AME?
Yeah, so this would be based on more morphology. Like benign lesions, like if we have fibroadenoma, or even like pleomorphic adenoma, which has more biphasic tumors, biphasic histology. And there's another, so there's multiple things that we can do differential diagnosis on the classical AME. So why it was divided, like there is this malignant component which is dominantly separate from AME, because the classical AME is not showing features of there's like which can be called as atypical or malignant. So the AME component shows the classic, like no cytologic atypia, there's no mitosis. So that's how. So this was a proposed classification of AME.
Thank you. Any other questions?
I have a quick question. Thank you so much. Very cool case. One of the last slides that you showed the table, I think same table that Jessie was talking about with the 3 different malignant AME.
Yeah.
I just noticed with the treatment recommendations that it says we consider hormonal therapy if the tumor is ER negative. So just wondering why are we considering hormonal therapy, and if you know why,
so
if
I'm
it's
not
ER
very
negative.
I'm not very familiar with that part, so I'm not going to discuss that's
Yeah, no worries.
the management part.
Okay.
Yeah, so I'm sorry about that.
No, that's okay. I was a little surprised to see that. And then the
Yeah.
other thing I noted was they recommended, or like optional breast biomarkers to be performed in the in situ, like AME, malignant AME in situ. So I was wondering, I guess in your
Yes,
experience.
yeah. So for AME malignant, AME invasive, or AME with invasive carcinoma. So the biomarkers are performed as we performed on a regular carcinoma, invasive breast carcinoma, the HER2, ER, PR. Those are performed on that invasive component, whether it's the AME with invasive or AME invasive.
Okay, what about the in situ?
So in situ, usually we don't perform the ER here. So maybe it will be treated or managed as DCIS, as we do in our regular the DCIS without AME.
Okay, thank you.
You're welcome.
Thank you very much. And then next we have Dr. Jessie from Lake Ridge.
So I'm Jassim Radi from Lake Ridge Health doing breast pathology. I'd like to share an interesting case which I actually come across recently, but this is a bonus. This is apocrine, and then there is a lobular carcinoma involving this insight. This is just a bonus. Okay, let me see if I can move to the next slide. Okay, so the clinical history, it was a biopsy from a 75-year-old female. She presented with a rather tender axillary mass, which was about 4 to 5 centimeters being described. So I think they decided to do a biopsy because they thought it could be anything, inflammatory or neoplastic. So they want to know at least a quick answer for this. So the biopsy came, and it was surprising. It's very cellular with very rather discohesive cells, large cells with polygonal or ovoid shape with hyperchromatic nuclei, abundant cytoplasm. So it's rather undifferentiated malignant tumor on the first look. So at this time you say, well, I should do, this is a higher power view of it. You can see there is those big cells with abundant cytoplasm with the nuclei pushed to one side in most of the cells. And there were some, as you can see, they're so discohesive cells. So you wonder what this could be, undifferentiated tumor. You would like to do immunohistochemistry to confirm. This is another review, which is actually nicer. You can see those cells, which are some sort of ovoid shape with a lot of pinkish dark cytoplasm and peripheral nuclei. As you can see, most of the tumor actually showing similar morphology. Being in the axilla, you could think of this as a lymph node with metastasis rather than something primary in the axilla, but definitely you think of many differential diagnoses and you look for a clue with the immunohistochemistry. So you did a lot of marker epithelial. First, I started actually with the breast, thinking it could be breast, female, and axilla. So GATA3 came negative, the biomarker, breast biomarker, they all came negative. So now you wonder, is this really a breast or something else? Well, let me start with the epithelial marker to make sure it's epithelial. So all the epithelial marker came negative. Then we start looking for melanoma. All the available melanoma markers were also negative as 100, melan A and HMB45. That's what was available a few months ago. They all came negative. Then you did a few other markers. Actually, SOX10 came some positivity with SOX10. So now you wonder, is this melanoma? Is this metaplastic carcinoma or some other things? Then while I'm working on it, the clinician called and you want to know, I said, this is a high-grade malignant tumor. It's a SOX10 positive. The differential may include malignant melanoma or even negative triple negative mammary carcinoma, but I don't have any positive epithelial marker. So I'm going to send it for PRAME out because it's present outside. We don't have that marker in our place. So while I'm sending it, the guy, they did actually investigate the patient for anything in the breast, in CT scan, chest, bone. So there was no breast or skin lesion or a previous history of melanoma. So they said, well, it's a single lesion, it's large, let's do excision of it and give you more tissue because your pathologists like bigger tissue. And it is. So we got actually a big 4 or 5 centimeter lesion, which is, you can see it's a lymph node capsule, and then there is this tumor cells here, which is no different from what we saw in the biopsy. It's sheets and large cells with pushed nuclei to the periphery with a lot of pinkish abundant cytoplasm. And this is another view of the same thing, a lot of pinkish cytoplasm and peripheral nuclei. So, and prominent nucleoli, as you can see in most of it, sometimes binucleated cells. And this is a nice high power view. As you can see, the cytoplasm, sometimes globular shape with pinkish eosinophilic, and then you have the nuclei pushed to one side with prominent nucleoli, and there's a lot of mitotic, so it's really a high-grade tumor. This is another good one, is where you can see all this globular structure within the cytoplasm, the eosinophilic globular structure. So you do repeat all the markers, everything came negative other than SOX 10, and interestingly, vimentin highlighting most of those cytoplasm. As you can see, all those cytoplasmic are really highlighted with vimentin. Some of them even has a globular shape with the nuclei you can see pushed to one side. There was some positivity for S100 in some areas, focal. So this is definitely different from the high-grade carcinoma, which we see. As you can see, it's different morphology. So it's you have to think of melanoma at this stage. GATA3 and SOX10 is useful for, let's say, breast cancer, especially the triple negative, but this is GATA negative as SOX10 is positive. And SOX10 said to be, I mean, is good for sensitive for melanocyte and other tumor too, but it's good for melanocyte. So at this time, we got the PRAME stain, which is, again, another good marker for melanoma, I've been told. And it was nicely positive, is actually in most of the tumor. So the final diagnosis came as a melanoma, and there is of unknown primary site. So I was actually thinking and reading about this melanoma. I found out that's about 3.2, or some places they say up to 8% of melanoma present with no known primary. They can be in the lymph node or subcutaneous tissue or even in the viscera. So, sorry. Where's this melanoma come if it is unknown primary site? Either the primary site regress, which was being described a long time ago. I haven't seen one, but it's been considered. But sometimes actually you can see regression in a melanoma, but to completely regress, I don't know, but that's what's been described. Sometimes you can get the other theory, they say it could be from a pluripotent stem cell within those lymph node or within, or as you know, also there are within the lymph nodes, sometimes you have nevus cells, and some people think they could come up from those nevus cells. Now, the morphology of this one was a little bit intriguing, interesting. It has those globoid as well as really pinkish cytoplasm. It's something like a rhabdoid type of melanoma. It's not a spindly, it's not just epithelioid looking. It really has more of some interesting feature which look like a rhabdoid. And those rhabdoid malignant melanoma, which have been described in the literature, a lot of them actually are negative for a lot of markers, Sometimes they may be positive for S100, but they lose the melanocyte markers. Interestingly, they stain for vimentin, which because they think those globoid structure or the cytoplasm has a lot of intermediate filaments. So this is our case, and this is what actually like rhabdoid tumor in the stomach, cancer in the stomach. This is what rhabdomyosarcoma look like. This is just to compare to this one. To some extent, there is this cytoplasmic globoid structure. Is this so? Then I was thinking I should find out if a PRAME was used in those rhabdoid-looking melanoma. And interestingly, there was a paper which said it's a helpful marker in those type of melanoma. And I also finish with this interesting, the neutrophilic, cystic neutrophilic granulomatous mastitis, which I've seen a month ago. Thank you.
Thank you so much. So yet another fairly rarely a rare entity here. Does anyone have any questions? Sorry. Just checking to see, are there any hands up?
Same. Was it confined to one lymph nodes or when?
Actually, when they removed, there was another lymph node positive. So it has to be coming from somewhere.
Okay.
But they haven't found it.
And how are they going to manage the patient? Do you know?
Well, they treat it as a melanoma, and they did actually some molecular studies as well on it.
Okay. Thank you. Excellent case. Thanks.
Thank you.
There's a question from the chat. Was BRAF done? And any molecular or any other molecular tests?
Yeah, I think they did molecular BRAF and c-KIT and other things, which I haven't looked at them, but they are done.
All right, thank you so much.
Okay.
So in the interest of time, we're going to move on fairly quickly to the next presentation from Dr. Ellen Yan from Mount Sinai Hospital.
Thanks, everyone. My name is Ellen. For those who do not know me, I just started being a breast pathologist at Mount Sinai Hospital recently. And just to go back to our topic from today, I actually recently published in Path Outlines with regards to breast therapy, immunotherapy in particular, and what emphasized on the use of PD-1 and its companion assays for the treatment of pembrolizumab. Okay, so now going back to our slideshow. Okay, let me know if you're seeing the correct screen.
Yes, we are. Yeah.
Okay, perfect. So, the clinical RAS history for this patient is that she's a 46-year-old lady with a history of right-sided, contralateral, high-grade, triple-negative invasive ductal carcinoma in 2016 at the age of 38. At the time, she was treated with neoadjuvant chemotherapy followed by lumpectomy with sentinel lymph node biopsy that demonstrated complete PCR and one benign lymph node. After that, she had also had adjuvant radiotherapy. Now in 2024, she presented now with left-sided palpable mass, and the MR on the right-hand side shows that in the upper outer quadrant, 10 o'clock, there was a rim-enhancing mass measuring 2.5 centimeter, and they noted that it was highly vascular. Subsequently, she underwent an in-house biopsy that showed a malignant neoplasm with chondrosarcomatous differentiation. And at the time, we showed it to bone soft tissue here at Sinai, and they said basically the differential includes metaplastic carcinoma or radiation-induced sarcoma, given her radiation history with chondrosarcomatous differentiation, and recommended excision. And here we have on excision. So in the right highlighted area, you see the heterologous elements with chondrosarcomatous differentiation. Adjacent to that, you see the spindle cell component, and surrounding that, you see the infiltrative glandular component that is consistent with MGA and atypical MGA. So here are some more higher power pictures of the chondrosarcomatous element and the spindle cell component. And even to the right, you can see that there's MGA creeping in to the side of the spindle cell component as well. The tumor was also associated with just run-of-the-mill MGA as well, just sprinkling through the fat, running around the tumor. And here we'll have a bit more of the atypical MGA in higher power with secretions and debris luminally as well and complex architecture. So here we have both MGA and AMGA in the same case. On the left, we have haphazard proliferation of small round glands with bland cytology, single layer photoepithelial cells with clear ovaculated eosinophilic cytoplasm uniform nuclei, open lumina containing secretions. And on the right, we have more architectural complexity, more interconnected microacini, cribriform nests, variable sizes and shapes and glands, and higher cytologic atypia. And here we have the immunostains. In terms of the chondrosarcomatous and spindle cell area, there was staining with P63. However, with PAN-K, CK5, and CK14, there was barely any staining. And also the tumor was triple negative, as was expected. In terms of S100 staining with the MGA and AMGA areas, you can see there is not a complete strong homogeneous strong staining with all these areas. However, you do have areas where it was staining stronger than others with nuclear and cytoplasmic staining of S100. And on the right, you can see that it does not have any SMMS or myoepithelial cell layer. So overall, at the time, we said favor metaplastic carcinoma with osteosarcomatous differentiation arising from atypical microglandular adenosis. Size is 47 millimeter, poorly differentiated 333, no DCIS identified, LVN not identified, margin was far away. Then we performed molecular studies on, first of all, the chondrosarcomatous area where we circled, actually we chose a block that only had chondrosarcomatous area and performed on that block, and that demonstrated TP53, this particular frame shift mutation. Then we also selected another block that only had the atypical MGA area, and that showed identical molecular changes. So just a quick reminder that out of the salivary gland type tumors under the WHO, adenocystic, secretory, mucoepidermoid all share the same fusions as our head and neck tumors, with the exception of cynic cell carcinoma. So there's this debate that's ongoing, controversial, whether or not MGA, AMGA is a precursor. So overall, I think the current understanding is that it's a non-obligate precursor, although there are studies that have shown that they're part of the same spectrum of lesions harboring frequent TP53 somatic mutations. And in terms of the molecular evidence, MGA and AMGA associated with breast cancer are associated with breast cancers are neoplastic lesions with recurrent TP53 mutations and complex patterns of gene CNAs. And they're all clonally related between the invasive carcinoma part and the MGA and AMGA part. And here's also another case report out of UCSF that showed pretty much identical to our study or our case here today, that they identify 3 mutational clusters and recurrent stop-gain non-synonymous mutations in both the ZNF, A62, and TP53D. Sorry. And just out of interest, this was actually a case shared to me from fellowship from MSK, that this was a area of atypical MGA that just happened to undergo neoadjuvant therapy. And you can see that the MGA now looks very histocytoid, a lot of single cells and small clusters. And it was staining diffusely positive strong for S100, CK7, and has a membranous at laminin staining in this case. So clinical follow-up for our patient in my case is that she was discussed at tumor board and it was decided to proceed with adjuvant chemotherapy for her secondary cancer. Also to note, she did undergo genetic testing and everything was negative at the time because her first cancer was quite young, and she's currently tolerating the last round chemo very well. And that's it.
Well, thank you very much, Sherilyn. That's yet another super rare entity. Does anyone have any questions they'd like to raise? Oh, so
Tumor size and margins. Tumor size. So in this case, we kind of treated the MGA as kind of acting as a DCIS. So no, we only included tumor size of the actual metaplastic parts. Good question.
Thanks, Ellen. That was an excellent case. Did you go back to the core to see if there was any evidence of MGA on it? Or I've had a few cases where patients for triple negative breast cancer have had neoadjuvant with excellent responses, and all we see in the excision is some MGA or AMGA. And when I go back to the core, sometimes I find a little bit of, it's easy obviously in hindsight, but a little bit of MGA that perhaps wasn't called at the time of diagnosis.
Right. It was a colleague of mine that sent out the box. I did pull the PIRE as always to compare from the core and the resection. There was no MGA at the time. Actually, there was predominantly like 90% of the entire core was just the chondrosarcomatous element. Hence why we showed it to bone soft tissue colleagues here at Sinai.
Great, thank you.
What about her first breast cancer?
It was high-grade invasive ductal carcinoma with just conventional DCIS.
And no MGA in the background?
No.
No.
Then it was 2016 at the age of 38. She did have radiotherapy after that. So
there's a question in the chat. Do you report the margins for the atypical MGA?
good question. So management for atypical MGA is that if the margins are involved, it's highly recommended for re-excision for clear margins. So we treat kind of in this case, we kind of considered the atypical MGA kind of just like an ADH DCIS. So I did email the clinician in hindsight and sorry, not in hindsight, in addition to my reporting, just to let them know the marginal status, but it was not formally reported, but it was widely clear anyways.
Excellent presentation.
Thank you.
All right, so I think that's everything. Thank you, everyone. And Anna, did you want to say a few words?
I would like to thank all the presenters and organizers and our amazing moderators for just wonderful cases and a very, very good discussion. And thank you for our keynote medical oncologist who presented his presentation. I think it was very valuable. Just to everybody, there is an evaluation form in the chat. Please copy the link, and especially if you're interested in the CME. But even if not, please submit your evaluation form to us for consideration for our next meetings. And thank you very much, everybody, and we'll see you at next events. And if I don't see a lot of you, happy holidays to all that you celebrate. And bye-bye now.
Thank you.
Thank you.